Well, early, in this occasion, we speak about early when they have moderate symptoms and not to wait after having severe. Here we speak about moderate. You know that in all of the trials, this is mandatory only to study women with moderate or severe symptoms, no with no symptoms. But your question is nice when you say, well, this is okay, but why not to prevent having symptoms, no? Exactly, it was your question. This is a beautiful analysis. There are a lot of colleagues that they prefer starting treatment with moisturizers or with local estrogens as prevention measure. But in fact, this is sub-analysis was done looking the phase 3 trials with ospemifene, and in the phase 3 trial with ospemifene is mandatory only having women with moderate to severe. That means that in this occasion, for me, early is to treat women with moderate symptoms. If you treat women with moderate symptoms, you are going to have a high proportion of women that they are not going to have any symptoms. They are going to relieve or cure, to be cured.
Yes, please.
Thank you, sir, for this very important issue. And just I'm wondering, you have told that it is ospemifene will work on VVA, vulvovaginal atrophy. So the IMS has taught us the new nomenclature, that is the Egarter syndrome of the menopause. So does ospemifene works on the other urinary symptoms? Number one, my question. Number two, you have showed here 12 weeks of your studies. So is there a head-to-head study between the local estrogen and the ospemifene? Or I mean, local estrogen therapy works for both all the urinary syndrome of menopause, not only the VVA. So what about your conclusion? Is the ospemifene better than the local estrogen?
Yeah, there are so many questions here. I'm going to start with the first one. I absolutely agree with you, but you know there are some roles when you are doing a phase 3 trial, and the authorities of the FDA authorities of the European Medical Agency authorities, they say that you need to look for the most bothersome symptoms, the most important symptom, you know? And always this is vaginal atrophy and dyspareunia. This is the reason why we analyze specifically, or more specifically, these two symptoms, but of course there are a lot. As you know, the famous change of the name to put or to add some urinary symptoms. But well, here the authorities, they decided that we need to analyze the most bothersome symptoms. In relation with the second one, I need to say that we have not any head-to-head trial between ospemifene versus local estrogen, but there is published one paper, beautiful paper now, and is ready, that we analyze indirectly, not directly, the results of the local estrogen studies versus the ospemifene trials. So we analyze they are analyzed the local estrogen and versus the result of the local estrogen trials versus the ospemifene trial, the most important one, the double-blind placebo-controlled studies. And we can say, we can summarize, and the conclusion is that the percentage of women that improve with the two treatments, they are very similar. That means that we can say that they are very the equal result in this way.
Thank you, Santiago. So I would like now to invite my co-chair, Professor Egarter from the University of Vienna and head of the Department of Gynecological Endocrinology, who is going to talk us about his research on phytoestrogens. Please, Christian.
Thank you very much, Irene. I'd like to cover quite a complex topic, and that is isoflavones and their use in menopausal symptoms. Isoflavones are components of plants, such as, for instance, soybeans, red clover, black cohosh, or even hop. Soybeans, for instance, contain at least 12 different isoflavones, mainly genistein, but also daidzein, glycitin, and so on. And soy food have been consumed by Asian populations for centuries. However, around 70% of isoflavones are lost by processing soy products. The daily intake is different in different areas. Hong Kong around 10 to 15 milligrams, up to 30 to 45 milligrams in Shanghai or Japan. And there is also a high inter-individual metabolism, because it could be demonstrated that only around 50% of Asians actually host the intestinal bacteria that convert daidzein, for instance, to equo, which is meant to be the main substance concerning sequelae. And only 25% of non-Asians exhibit this intestinal bacteria. So what are actually phytoestrogens? This is a class of relatively divergent structures. Flavones, isoflavones, saponins, stilbestrol, all belong to the family of phytoestrogens. And since a few years, the term phytoserms has been established, selective estrogen receptor modulators, because they modulate the estrogen receptor, either the alpha or the beta receptor. Because as you know, we have two different subtypes of estrogen receptors. We have the subtype alpha and beta. Both display a highly conserved DNA binding domain and a moderately conserved ligand binding domain. Both also have an activation function 2, and the subtype alpha has an additional activation function 1. And actually, you have to imagine a receptor as a three-dimensional structure, which upon interacting to an estrogen, for instance, changes, a conformational change of the structure. For instance, highlighted here in blue, especially the helix 12 is moving to a certain position when an estrogen is bound, whereas when another substance, an estrogen receptor modulator or a phytoestrogen is bound, this helix 12 depicted in green here is in a complete other position. And that in turn leads to areas on the surface of this receptor construct that are free, and these areas are other areas, different areas than when an estrogen is bound. Because what happens on a subcellular level is when estrogen or a receptor modulator comes in and binds to the estrogen receptor, there is dissociation of heat shock protein 90, then dimerization, and then translocation directly to the estrogen response element on the DNA. And the next step is the activation of different cofactors, either co-activators or co-repressors. And the final step usually is the activation of basal transcription apparatus, mainly the RNA polymerase II, and that finally leads to activation in case an estrogen is bound to the receptor, but in case a SERM is bound or a phytoestrogen is bound, there may be some modification in transcription or even a suppression in certain cases. And what makes the story a little bit more complex is that within different tissues we have different cofactors. For instance, steroid receptor co-activator subtype 1 is more present in the endometrium, whereas subtype 2 is the main cofactor in breast tissue. And we know up to around